Good evening and welcome to the EU webinar called Outstanding Challenges in Medical Treatment of Male LUTS and BPE. My name is Christian Gratzke. I am a urologist from Freiburg in Germany. And I'm very pleased to welcome you to this webinar. We already had one webinar and there's one more webinar coming up June 1st, which I'm going to relate at the end of this webinar. So today, we're going to talk about medical treatment of male LUTS, and I'm really happy to present to you two excellent speakers. First, we'll have Dr. Tarkan from Istanbul, who will give us a lecture and a case discussion on the mono treatment of male LUTS, and then Dr. Jean-Nicolas Cornu talking about combination treatment. So let's start the first one. Dr. Tarkan from Istanbul, the stage is yours.
Thank you very much, Professor Christian Gratzke, Professor Jean-Nicolas Cornu. It's a great pleasure, honor for me, again, to be in this webinar. Once again, thanks a lot for the very kind invitation of the European Union. Yeah, I actually did the first part of my lecture, which was about the essentials of monotherapy in male LUTS. And I basically spoke about alpha-1 blockers and 5-alpha reductase inhibitors in that first part. Just briefly, I would like to summarize the main take-home messages from this first part. Well, male lower urinary tract symptoms are multifactorial and they do not necessarily indicate bladder outlet obstruction. So we are talking about a multifactorial etiology here. Alpha-1 blockers, with no questions, are the most commonly utilized monotherapies in that patient group. They are considered as the first-line medical treatment all over the world. They have a rapid onset of efficacy, and all alpha blockers do have actually the same efficacy. However, they may differ in terms of their side effect profile depending on their receptor subselectivity. We know that as a class effect, all alpha blockers decrease the bladder outlet obstruction index. However, there may be also a multimodal mechanism of action, which is actually not clearly understood yet. 5-alpha reductase inhibitors show their first clinically significant difference compared to placebo after 6 months of treatment, and they reach a maximum efficacy after 2 years of treatment. They actually improve the IPSS and increase the Qmax similar to alpha blockers. However, they are not suitable for short-term use. In addition, they reduce the long-term risk for acute urinary retention and need for surgery. And furthermore, they decrease the prostate volume. So this was basically what we have talked in the first part of my lecture on monotherapy on male LUTS. Now I would like to share with you a simple case, and then I would like to please get your opinion on the treatment options for this patient. This is a 48-year-old healthy man with benign prostatic enlargement and lower urinary tract symptoms. You see the IPSS score is 18 and mainly including storage symptoms. His quality of life is quite affected. He has an active sexual life. His prostate is measured as 40 milliliters on ultrasound. He doesn't have a median lobe. His PSA is 1. The bladder diary revealed decreased voided volumes reaching a maximum 200 milliliters. He has increased frequency and he doesn't have nocturnal or global polyuria on bladder diary. And he doesn't have incontinence. You see his repeated uroflowmetry results on the slide. On average, his Qmax is 16. Qmax is 16, Q average is 9. His voided volume is 200 milliliters with a residual volume of 10 milliliters. So what would be your best choice to offer to this treatment-naive patient after conservative measures have failed? Alpha blockers or antimuscarinics or PD5 inhibitors, or beta-3 agonists, or surgical management or any other treatment option.
So the voting is started, and we would like you to give us your opinion and your recommendation on this patient, and then we'll see the results of your poll.
Okay. All right.
All right.
Okay,
so
we got the results, Christian.
This is basically a very clear answer. 70% voted for an alpha blocker, 14% for a muscarinic receptor antagonist, 4% for a PD5 inhibitor, 7% beta-3 agonist, and there are 4% that are true surgeons among us that would say need to operate on this patient. Dr. Tarkan, you've dealt with the patient. What would have been your choice? I'll then ask Dr. Cornell also, but first, please go ahead and let us know what your opinion is.
Well, actually, I have to first tell that there's no single correct answer for this question. Actually, the general attitude of the urologists is already shown on the poll. Many of the urologists will start just thinking of a 40-gram prostate here, an alpha blocker in the first line. However, studies have shown that also monotherapy here may work very well on this patient, just with antimuscarinics and Mirabegra. So I think this patient with a Qmax of 16, very good bell-shaped curve of uroflowmetry, and mainly storage symptoms may also be started with an antimuscarinic treatment or beta-3 agonist. Of course, the other way, starting with alpha blocker treatment and seeing what's going on, thinking that alpha blockers are also effective in treating storage symptoms, and then maybe adding an antimuscarinic or mirabegron if alpha blocker treatment alone is not efficient, is also another way, another correct way or good way or reasonable way to follow.
Now, thank you very much. Jean-Nicolas, you are from France and you work in Rouen. And I know that in your country, herbal treatment has been really popular over the years. And we have one question coming in saying, would you consider phyto treatment? Thank you.
Yeah, as you know, thank you. It's a very good question because currently the guidelines consider that the data we have for proposing phytotherapy here are not sufficient to get a recommendation. For sure, we wouldn't have much secondary effects or adverse events with such a treatment, which obviously cannot be stated for alpha blockers or antimuscarinics. I would say that in that case, phytotherapy could be considered if the guy really doesn't want these secondary effects. We see on the current slide that he can be considered as someone who is bothered, but maybe who really does not have crude obstruction and bladder outlet obstruction based on the data we have. So I think it's not a mistake to do it. But what I see here on this slide is that this patient is classified as a male LUTS patient. Why shouldn't we classify him as an OAB patient? Because if you have an IPSS of 18 and mainly storage symptoms, you would consider that this patient has maybe overactive bladder and that the prostate is not necessarily the cause of his symptoms. And now at this stage, with this view, you get out of the phytotherapy indication. So I think it's not a typical indication for this. We know we proposed phytotherapy rather for elderly patients who mainly have symptoms mostly related to BPO.
That's also what one colleague asked Dr. Tarkan, that's the last question before we should maybe go on with your presentation. But the question is, why not subdivide IPSS into storage and voiding symptoms together with the uroflowmetry? Our colleague thinks that that would be the best answer. So combination of uroflowmetry and a subdivision of storage and voiding LUTS of the IPSS.
Yeah. Okay, so I think I can follow, or was there a question? I didn't get any.
So that was,
that remark?
maybe it was more,
yeah, that was a remark.
It was a remark, but you can just maybe comment or just go on.
No, I agree with that. So IPSS, when we look to IPSS, we have to classify the symptoms. That's right. And we have to also keep in mind that IPSS doesn't have any incontinence score. So this patient doesn't have any incontinence, but we have to keep in mind that as well. So again, as Jean Cornu has very well stated, this patient may be an OAB patient as well. This patient may be obstructed as well. So we don't know that. But still, I think these are all viable treatment options. The only thing that I wouldn't agree with the results is the doing surgical treatment on this patient. I think this is not a good way to go. There is a high chance for these patients being unobstructed. So if we consider surgical treatment on this patient at any time in his treatment course, we have to do pressure flow studies for sure. So if I may continue with the slides. So after talking about alpha-1 blockers and 5-alpha reductase inhibitors, another option for monotherapy are the antimuscarinics, as we can think as a viable option for the previously presented case. Because LUTS in men are not always caused by the prostate. This is something that we know very well. And as a consequence, actually, antimuscarinic treatment is strongly recommended by the EAU guidelines for men with moderate to severe LUTS who mainly have bladder sporage symptoms. And there is a level of evidence too who is supporting this actually recommendation. So there are all the antimuscarinics available, as you see on the right side of the slides. Of course, not every antimuscarinic drug has the same evidence for that. But if you look to the randomized control trials, antimuscarinics in terms of safety appear to be good in the short term in 12-week trials. In randomized control trials, the withdrawal rate is similar to placebo, and we see actually the class side effects of antimuscarinics in all these studies, like dry mouth, constipation, micturition difficulties, nasopharyngitis, and dizziness. Just we have to keep in mind that the residual urine in all these RCTs are kind of normal or low. So we have to be careful with residual urine. But if there is no bladder outlet obstruction, of course, there is no actually, or there's little risk, let's say, for an increased PVR in all these studies. But the question is, what happens if we start antimuscarinics on a patient with bladder outlet obstruction? Abrams and Associates in 2006 have studied this. And this was a randomized study, tolterodine versus a placebo. Here, tolterodine increased the residual urine, but not increased risk of acute urinary retention in that study group. The tolterodine group had larger bladder volumes at first episode contraction, higher maximum systematic capacity, and decreased bladder contractility index. However, the Qmax was unchanged. So although this trial was a short-term trial, the antimuscarinics in that trial were found to be safe in terms of the risk of urinary retention and increased PVR, which was clinically not significant. But still, of course, the EAU guidelines recommend that we should not use antimuscarinics in patients with residual urines higher than 150 milliliters, because we do not know in the long term what's going to happen to these patients. And in every male LUTS patient, we we have to follow the patient closely with IPSS and PVR measurements. Certainly, we need further research in that field, first of all, to test all antimuscarinics, and especially the elderly data is not available for all antimuscarinics here, and long-term studies are needed to see the effect of antimuscarinics on bladder dynamics in intervals more than 1 year. Another monotherapy option that we have is the phosphodiesterase 5 inhibitors. The basic theory is the PDE5 inhibitors increase the intracellular cyclic GMP and so reduce the tone of the bladder smooth muscle. But there are also other hypotheses to explain maybe the multimodal mechanism of action of PDE5s. For example, they may alter reflex pathways in the spinal cord and transmission in the urethra, prostate, or bladder. Chronic treatment is shown to increase the blood perfusion and oxygenation in the lower urinary tract, or also they have been shown to reduce chronic inflammation in the prostate and bladder. So the exact mechanism is still not known. Tadalafil, 5 milligram once daily, is the only licensed form for male LUTS. The Cochrane 2018 review included 16 randomized controlled trials. There was no difference between PDE5 inhibitors and alpha blockers in terms of IPSS change, and the Qmax did not significantly differ from placebo in most of the trials, not in all, but in most of the trials. But most evidence was limited to short-term treatment up to 12 weeks and of moderate and low certainty. So the discontinuation rate due to adverse effects was also very low, with 2%. Again, in all these studies included the class effects of PDE5 inhibitors, which we know very well from the ED studies. And the contraindications are also the same, what we know with the PDE5 inhibitors. Patients using nitrates, the potassium channel openers, or the alpha blockers, doxazosin and terazosin, should not use the PDE5 inhibitors. And patients who have unstable angina pectoris or certain degree cardiac disease are not also suitable to use PDE5 inhibitors, with another precaution with the patients with anterior ischemic optic neuropathy, which may lead to sudden loss of vision. So the evidence says that PDE5 inhibitors in monotherapy also improve the IPSS, also the IIEF score, but not Qmax. That is supported with a low level of evidence of 1A. And also with tadalafil, we see a more than 3-point IPSS improvement in 60% of patients within 1 week, but this goes up to 80% within 4 weeks. So the recommendation is, again, here to use PDE5 inhibitors in men with moderate to severe LUTS, with or without ED, and that is recommended strongly by the EAU guideline. And the last molecule that I'm going to talk regarding the monotherapy of male LUTS is Mirabegra. Mirabegra has the main theory to affect the beta-3 adrenoreceptors in the detrusor muscle, and so induce detrusor relaxation by stimulation of cyclic AMP generation. This is the main theory, but also there are other hypotheses to explain the mechanism of action, which is not clearly understood in the bladder. These include opening of potassium channels, inhibition of spontaneous contractile activity in the bladder, and reduction in bladder afferent activity. The only main contraindication of Mirabegra appears to be the severe uncontrolled hypertension. In all randomized controlled trials in 12 weeks, Mirabegra was not associated with any increased risk of hypertension or cardiovascular events compared to placebo. So if the hypertension is under control, it doesn't appear to be a contraindication of Mirabegra use. Another advantage of Mirabegra appears to be that the common side effects of antimuscarinic, dry mouth or constipation, is not seen with Mirabegra, or they are similar to placebo. We know that these side effects are important in patients' adherence to the treatment, and therefore the patient adherence of regarding mirabegron seems to be better compared to antimuscarinics. So what is the urodynamic effects of mirabegron? Again, actually, we need more studies in that field, but I would like to share with you the study from Nitti and Associates, who evaluated 200 men older than 45 years of age and who have bladder outlet obstruction. These patients were randomized to either mirabegron 50 milligram or 100 milligram or to placebo for 12 weeks. Mirabegron once daily of either dose had no negative effect on voiding urodynamics compared to placebo after 12 weeks of treatment. And the overall change of PVR was not clinically meaningful even with the dose of 100 milligrams. So this study has shown that mirabegron actually does not negatively affect the voiding dynamics, at least in 12-week period in patients with bladder outlet obstruction. So the evidence is that the mirabegron improves the symptoms of OAB, including micturition frequency, urgency, and urinary incontinence at the level of 2. And patients on mirabegron remain longer than patients with antimuscarinics on treatment. So the patient's adherence is better compared to antimuscarinics. So the recommendation comes from the EAU guideline again, that we can use beta-3 agonists in men with moderate to severe LUTS who may have bladder storage symptoms. The recommendation is, I think, if I'm wrong, please correct me, weak, but this recommendation may change soon with the more coming data to show the safety and efficacy of mirabegron. Certainly, we need, again, here more studies, especially long-term data in the elderly population will be very intriguing for us to know. So these were actually the topics that I would like to share with you about the monotherapy. I know that I have not covered phytotherapy as monotherapy here because of the time limitation, but I know that Gian-Nicolo has much more experience than me about phytotherapy, so maybe he may fulfill this gap in monotherapy. Thank you very much for your very kind attention.
Thank you very much. That was a very nice and clear, straightforward presentation. We actually have a lot of questions coming in, and I would like to start with these questions. One is actually still related to diagnostics. Measuring prostate volume transrectally or transabdominal? Can you just give us just a short answer? What's your preferred option?
Sure. The transabdominal measurement is actually the most commonly utilized method because of the invasiveness of relatively invasiveness of transurethral ultrasound imaging. So transabdominal measurement is good enough.
Any role of alpha blockers for lower ureteric stones? A bit outside the box here.
Yeah, we are outside the box here. Well, there is controversial data here, actually. Some studies are showing that they help, some do not. So I'm not an endourologist and dealing with stone disease. So I would like not to comment, actually, much on this question.
Okay, I guess it's actually, some would argue, why not giving it to the patient if it doesn't hurt? Whether it helps, we don't know, but I guess one thing is for sure, in the upper ureter it doesn't work because there's no alpha receptors that we know, but we leave this for the stone experts and the stone webinars. But there's an interesting question coming in. Could we add other PDE5 inhibitors in patients with erectile dysfunction who take already Cialis 5 milligrams for their male LUTS?
Who take already 5 milligrams. If I understand this question correctly, So are we talking about a combined usage,
No,
or?
The question relates to somebody who is taking Cialis for male LUTS, but still has some erectile dysfunction problems. Can he take 50 milligrams sildenafil on top of that?
Well, I really don't know. I don't know any study actually answering this question. Again, this is also outside the box question. And if of course, if the erectile dysfunction of the patient doesn't answer to Cialis 5 milligram, we may need to change maybe to 20 milligram. First of all, maybe every 48 hours, or try other treatment modalities, but using at the same time sildenafil plus tadalafil is something that I wouldn't advise.
One question is, I would specifically like to hear Tarkan's opinion on antimuscarinics and old age, which is best for the old, frail patient with senile dementia. This is a good question, really. Unfortunately, antimuscarinics are actually have the warning to be used cautiously in the elderly population. And this is because of several factors. The first one is the cognitive side effects of antimuscarinics. And we know that in the elderly population, the antimuscarinic load, which is originating also from the polypharmacy, is quite common. And plus, the long-term use of antimuscarinics are shown to affect the cognitive function in the elderly. So this would be my main concern using antimuscarinics in the elderly. So again, another question is, of course, we have to define what we mean with the elderly. Are we just dealing with just patients older than 65 years of age, or are we talking about frail elderly? So in the frail elderly, older patients with comorbidities, I think antimuscarinics should not be used unless they are just very much needed. And in that case, I would go for a beta-3 agonist instead of antimuscarinic especially in that special patient population. Thanks. Jean-Nicolas, one short question. Any role of Botox in storage LUTS?
Yes, that's a good question, because sometimes I think it's supposed when medications do not work, because we all agree to start with less invasive treatments like antimuscarinics or beta-3 or even PTNS in the case of very frail patients. But Botox in men is something that is to be used carefully, because you know that all the studies that have been conducted in idiopathic OAB, storage symptoms, included mostly women. So actually we lack some data about Botox in men, especially in the male LUTS area. And one important point is the obstruction. You know that Dr. Tarkan has shown that urodynamics effects of beta-3 and antimuscarinics may not be a big issue even when you got a bladder outlet obstruction. It might not be the case in men. I would advise urodynamics before to check if there is an increased risk of urinary retention using the Botox, and the dose is also important to consider. Anyway, when you talk about surgery, neuromodulation is also something you would consider for OAB in men. So that's for sure not a cut and dried decision. You need to consider all the opportunities, but one thing is that we lack data significantly on that point.
Thanks very much. I think many questions refer to combination. We're going to deal with this later. But one last question on Mirabegra. When is the dosage of 25 milligram Mirabegra indicated?
Well, this dosage is an alternative, to the standards that have popped out from the clinical trials initially. What we have seen with Mirabegra 100 is that it doesn't bring something much compared to 50. So that's why the dose of 50 has been recommended based on the initial pivotal phase 3 trials. The dose of 25 is more indicated in patients with metabolic conditions like renal impairment, or when we anticipate that there might be some accumulation of the drugs. So this is not because of there is bladder outlet obstruction, for example. You cannot consider I would do the half dose of Mirabegra so that my patient doesn't get a PVR increase when there is no science behind this, but that's mostly related to the metabolic condition.
Tarkan, last question, very specific case, 54 years old man with a 70-gram prostate, IPSS is 10, PSA is 2.6. What's the best treatment?
Yeah, actually, we can talk here about a couple of best treatments, but I'm trying to follow the question. I've lost it. This is a big prostate. We do not know, unfortunately, the uroflowmetry result. But this patient, if his quality of life is bothered, then of course we need something to start with. And this will be, of course, for me, an alpha blocker to start with, and then combine it with a 5-alpha reductase inhibitor if his symptoms, uroflowmetry, and quality of life does not respond enough to alpha blocker mono treatment.
So having said that, maybe another option would be to start off with the combination treatment, alpha blockers and 5-ARIs right away. And this is, Jean-Nicolas, I think, where your presentation kicks in. So thank you very much, Tarkan. We'll catch up later and we'll start Jean-Nicolas' presentation now.
I would like to go on the cases about combination therapy. In our pre-webinar recording, we have discussed about the potential need for an additional treatment in patients with still voiding symptoms after alpha blocker prescription. Now today we'll discuss in line with what has been discussed before about a patient with storage symptoms. So this is the case of a 67-year-old guy. He has voiding LUTS. Let's say it's mixed symptoms. This person was prescribed alpha blockers, alphazozine, 1 year ago, and he's still taking the pills. So he was quite happy with that because in the initial phase and during early follow-up, he has been satisfied regarding the voiding symptoms. But he still wakes up at night several times to urinate. And if you look at the IPSS, it was 22 at the beginning, it dropped to 16, but still we have here some, in the vast majority, storage symptoms, and he is still bothered. This guy is not sexually active. In that storage symptom context, he has no hematuria, there is no red flag, he's never smoked, and there is no UTI in the recent history. So you know that in that case of predominant storage symptoms, we have bladder diary. That is the cornerstone of the evaluation of the what we could call the OAB symptoms. And actually, this guy could be classified as an OAB patient because you see on this bladder diary that this patient has the urgency episode, which are notified in the middle, in the column in the middle by UM, means he has micturations with urgency several times a day. You see there is obviously an increased frequency with urination closer to every 2 hours, with more than a dozen times on a 24-hour round. And maybe the most important information we got here is the exact number of nocturia episodes. You know that only bladder diary is able to report that correctly because people might overestimate that. You see that there is no nocturnal polyuria because if you do the math and if you addition all the micturations per night, it doesn't go in a significant percentage of overall micturition and 24-hour volume. He has no incontinence, but a very important information you got here is that he has a reduced bladder capacity. This guy is not able to void more than 140. So that's a very difficult situation, because when you see this type of patient, or you would anticipate to do uroflowmetry, but you know that uroflowmetry may not be possible to correctly interpret when you have less than 150. But in that case, that would be the case anyway. So the further explorations have shown that urine cytology was normal. He underwent an endoscopy, actually by one of our chief residents here. There was no bladder tumor, no inflammation signs, and no stone in the bladder. Ultrasound shows a 65 grams prostate. Actually, we should say milliliters rather than grams, because we do not weigh the prostate when we do ultrasound. There is no other abnormality, and the index of prostatic protrusion was classified as low, but it was not clearly measured. The uroflowmetry has shown a 12 milliliter per second Qmax with a curve that was classified as acceptable. Remember that it is under alpha blockers, and a small PVR was shown as 45. So now you have everything in mind here. Your patient is under alpha blockers, and he is asking for a treatment. He's asking for something more. What I would like to discuss with you today is what would be your best proposal in that setting. So it's quite different than the monotherapy discussion we had before. Here we have to either keep the alpha blocker and add antimuscarinic, proposition 1. We could keep an alpha blocker and add beta-3 adrenergic agonist, namely Mirabegra, because it's the only one available in most of our countries. One question would be propose botulinum toxin injections or neuromodulation, or switch again to surgery. Please vote now.
Excellent question. Thank you very much, Jean-Nicolas. I'm voting too. I was actually going to ask, and I would be interested to know how many of our colleagues in the audience do neuromodulation, because as far as I know, still that is limited to certain centers, which limits its availability. But maybe we can talk about this later, because I know, Jean-Nicolas, you're an expert on that. This is the answer. So keep alpha blocker, add antimuscarinics, which is a little bit ahead of alpha blocker and the beta-3 agonist, Mirabegra. 3% would actually propose Botox, 2% neuromodulation. That's confirming my estimation. Maybe that's just not being done in many centers. But again, we have surgeons, 9%. That's a lot to switch to surgery. Maybe we can start with the last one. Is anybody, Jean-Nicolas, would you be doing the surgery on this patient?
Yeah, personally, I would not consider it right away. I know that Dr. Tarkan is thinking the same, because it's not that simple. Maybe you will end with surgery on this patient, but we minimally agree as experts in the field that these cases first need urodynamics before surgery. That's pretty sure, because there may be bladder outlet obstruction in that case. Since it is not, I would say, solved by alpha blockers, in theory, surgery could be discussed. But the complaint of the patient is based on storage symptoms. And we know that when you operate a patient with storage symptoms, if there is a bladder outlet obstruction, first condition, if there is bladder outlet obstruction, the only way to be sure is urodynamics, you have 50% chance to heal the storage symptoms. That would be, an ideal case when you operate the guy and he doesn't need anything and he is perfect. but you have 50% chance that it absolutely doesn't work. And you may have even patients who are doing worse after surgery with incontinence or even increased unmasked OAB. So I exclude the cases, of neurogenic people, everything. That's for the general case. Namely, I would say that urodynamics and think twice are the two take-home messages related to a switch to surgery here.
Any role of Desmopressin in this case?
No.
No, that's a clear answer.
No.
Well,
no,
the patient,
because you would discuss that. I insisted on that on my presentation. You would maybe discuss that if there is nocturnal polyuria, because in the OAB field we had this question, and you would be happy to remember that in all the studies that assess desmopressin, you have initially a filter to get the patients in to check that there are nocturnal polyuria. It's not well known by all the people, but if you really do not have this, you might not be able to translate all the level 1 evidence we have, because it does exist against placebo. But I insist on the case of nocturnal polyuria, which is not the case here.
All right. I think we have many more questions, but maybe you want to proceed with your presentation first. We'll have some questions answered, and then we'll deal with the questions.
Sure, correct. So I will make it clear and loud so that we do not lose a lot of time on the lecture and maybe discuss more. So what we could consider here is that first, the guidelines are very clear. They are very clear on antimuscarinics, and that's why it's the majority, but you see that beta-3 agonists went close to the results in the voting, but the combination of alpha blockers and antimuscarinics is indeed what is recommended strongly based on real demonstrative evidence from the guidelines. It's good to improve quality of life. It's good to reduce urgency, urinary urgency, incontinence, voiding frequency, and nocturia. You would anticipate the adverse events that Dr. Takan has mentioned before, in combination, of course, with alpha blockers. The rule in combination treatment is that you usually are exposed to both of the adverse events of each drug. That's perfectly logical. So that's a strong recommendation. And it's included in the diagram, the decision tree of treatment. So you see here that storage predominant symptoms, like Dr. Takan was saying, it could lead to an antimuscarinic at the baseline. This is what we discussed before. But if you have an alpha blocker prescribed, and if you have residual storage symptoms, that's more on the left, you would prescribe the muscarinic receptor antagonist or a beta-3 agonist. So that's exactly what has been discussed by the audience today. And that's excellent to see that. So why is there a rationale for this about efficacy, safety? Is that true for all patients? Is that bankable in the long term? This is the questions we have. So briefly, if we look at two modern drugs like, say, fesoterodine and solifenacin, we have some efficacy data compared to alpha blocker alone. If you associate in this study alpha blockers plus feso, you would improve the IPSS storage, as you see that, and especially in the patients who still have a good Qmax. So in green, you see we have a drop of the IPSS storage part, which one was of the questions before, that is significantly better than alpha blocker plus placebo. In this other study, well known from European urology by Van Kerbroek and colleagues, there was a combination of tamsulosin, OCAS, and 2 dosages of solifenacin, and related to the IPSS storage again and the micturations per 24 hour, you see there was a great significant improvement of the combination therapy. So when we look at this in the long term, if we see an extension of this trial published later, 2 years after the start of the study, for up to 1 year, you see that this is quite maintained as we have the IPSS kept down until 1 year follow-up. So that's quite interesting for the midterm outcome and what you say to the patient. So what about the tolerance? We have seen that before, that pressure flow studies might be important to consider, and also urodynamics. Dr. Takan said that based on very nice trials and close to level 1 and 2 evidence, we have no real impact of antimuscarinics on the bladder outlet. Here you see that within a combination, if you look again, the effects of alpha blockers and combinations, we have a flow rate that is not really impacted by the solifenacin addition. And there is a non-inferiority to placebo compared to combination therapy, I mean alpha blockers plus placebo. If we look at the PVR data, we have some meta-analyses that are showing that this combination therapy is not associated with the really clinically significant mean difference. And this is also the case for acute urinary retention. It may be a concern for our colleagues when you introduce these antimuscarinics plus alpha blockers. You will see anticholinergic plus alpha blockers. You don't have a real significant difference in this meta-analysis in the two groups in terms of occurrence of AUR. But you see that the combination therapy regarding the symptoms, we have a true efficiency regarding the 24-hour micturations and the urgency symptoms. So for the storage subscores, you see that co-therapy, I mean, combination therapy is favored, and it's the same also for quality of life. Remember that storage symptoms are one of the most important symptoms for quality of life. It impacts dramatically the quality of life of patients. If you look at the persistence, it's in line with what we said before. If you look at what happens under combination therapy, the probability of staying on treatment is quite low when you introduce the antimuscarinics, but it's comparable to the data with antimuscarinics alone. So this is something we have to remember, but you know, it's not really different. Maybe the persistence could be considered as low, but we have some answers maybe with the Mirabegra. So this is the second issue. I know that close to 50% of people here choose this beta-3 agonist. It is recognized by the EAU guidelines. As Dr. Traken said, it's a weak recommendation when we look at alone in monotherapy. What about combination therapy? It is not exactly the same theoretically. So we know that in male population, Mirabegra has a nice efficacy, and it's right comparable to the antimuscarinics in males. Is true for urgency episode, which is a very important factor to consider, and it's also true when you have incontinence episodes. So if you look at the secondary effects, you see that we have no dry mouth, of course, compared to antimuscarinics. We show a high rate. Hypertension is comparable, and also constipation. So if we look at the combination, what can we say about this? On these very difficult slides, you will see that if you look at all the trials for about 3 months of Mirabegra and tamsulosin, it's the 3 first parts we have here, the Ichitara, the Kikizaki, and the Kaplan studies. There are RCTs comparing an add-on therapy of Mirabegra 50 compared to tamsulosin plus placebo, which is exactly the question we are asking. And we see that we have really significant results with good tolerance of Mirabegra with no safety concern. But you see that these results show a bit of discordance and maybe not perfectly clinically significant, because when you see an IPSS of -2.3, it's under a variation of 3 points. When you look at the number of micturition, it's -0.4. Volume per micturition is 9 milliliters. Unless it is significant statistically, you could be worried about the clinical efficacy, but that's still under scrutiny right now. So it's quite promising, but we have some issues regarding the Qmax and the underlying obstruction. So the other potential resources, as Dr. Tarkan said, are also for the combination field, the PDE5 inhibitors. So we had already a number of studies that have tried to combine these therapies. So we have some RCTs, like, for example, comparing tadalafil to dalafil plus Mirabegra. This is the Yamanishi very recent study, when we see again something significant on the OAB component, but not on the IPSS component. We have the tadalafil compares to fesoterodine, again with symptoms that seem to be improved also. And we also have the ongoing RCTs, like with the Vibegra, which is a new molecule. That's just the landscape of what is going on. Obviously, it doesn't lead to any recommendation right now, because these studies are overall weak. But it's just to show you that the field is moving, and every year you might find a difference, an update of the clinical guidelines. So if we summarize that, and it's really opens to me the discussion. If we look at the beta-3 agonist, we have talked about that. The data are quite solid. We don't have long-term results, as Dr. Tarkan said. It's well tolerable. We see that people do not stay for ages under the drug. It's instantly reversible compared to surgery or Botox, for example. We have hypertension as a warning, and it's considered as a second line after conservative management, as we say by the guidelines. When you look at the other ones, which we discussed a little bit, in parallel with what I said before, Dr. Tarkan has talked about the PDE5. But if we look at the Botox, for example, the data are really poor in relation with what I said before. We don't have long-term results. It works for months, but it's invasive. You would have to repeat that. And if you get under retention, CISC, clean intermittent self-catheterization, it would maybe last for months, since the efficacy is up to 6 months. So the retention is really an adverse event to consider. Today, it's considered as interventional or third-line therapy. PTNS is quite non-invasive, but we have very weak data, as surprising as it should be considered. But in men with LUTS, idiopathic situation, we have relatively weak data. So today it's only a third-line treatment. And SNS is on the same way of recommendation compared to Botox. It's interventional third line, and we all know that the data are scarce. Long-term results, again, absent. It's many invasive. You would maybe consider that if there is associated bowel problems, but as you said, it's not widespread in all the community. It asks the question of cost. It's a kind of lifelong therapy. I mean, it's at least presented like this. And the reversibility, again, needs surgery. As you all know, the drawbacks are infection and chronic pain on the device position. So I think that opens discussion, and I would be happy to continue that with you. Thank you for your attention.
Thanks very much, Jean-Nicolas. Great presentation, very intense. Let me go through some questions. We only have a couple of minutes left. What about combination of an antimuscarinic with dual DARTs? So that's combination treatment of dutasteride and tamsulosin with a patient that has a prostate of more than 45 grams.
Yeah, that's a very excellent question. This is the field of tree therapy, which I did not cover today. Excellent question. So I personally, I already did that because there is nothing really against. So if you have the voiding symptoms that have been treated with alpha blockers and a 5-RI, I think if there is remaining symptoms, you would be able to translate the science we have and test the antimuscarinics. Remember that if you don't have a big residual, if you well know your patient, you are confident in your diagnosis, where there is no red flag behind, why not?
Trying to summarize some of these questions, Dr. Tarkan, any comment on any of these drugs in a patient with prostate cancer that has received radiotherapy or HIFU?
We can hear you, Tufan.
All right. Sorry. Yeah, these cases are really very challenging, and unfortunately, there is very little data in the literature to reach a high level of evidence. But for the both Mirabegra and antimuscarinics are used in these patients, but unfortunately, there is no high level of evidence showing success. The radiotherapy and HIFU issue is really something different than male LUTS.
Any role of finasteride as a monotreatment for minimal LUTS? Our colleague asked.
Yeah.
For a patient with a massively large prostate?
Yeah, in the long term, we know that both finasteride and dutasteride reach the same symptomatic improvement as we reach with tamsulosin. So in the long term, actually, even with the combination treatment, there is a chance for us to stop the alpha blocker and continue only with the 5-5-reductase inhibitor. So the question is, yes, if the patient doesn't need an acute, rapid onset for action.
Jean-Nicolas, can Mirabegra be used in a patient who receives beta blockers? I guess for hypertension.
Oh yeah, that's an issue we sometimes have. It's not contraindicated, so you are not at risk of anything, but you would check with the cardiologist that it is compatible. I always do that. I prescribe this drug a lot, but if there is any background like hypertension, the contraindication is severe untreated hypertension. If you are on drugs, probably you are treated, so you don't have severe hypertension. But you would check that with the cardiologist, and more importantly, check at home or with the doctor, family doctor or pharmacist, or what you want, the blood pressure like 10 days after introduction of treatment to check it doesn't change it.
Last question, Tufan, any benefit of alpha blockers in females?
Well, let's say a marginal benefit only for women with bladder neck dysfunction or dysfunctional voiding. Some studies have shown some marginal benefit. Some studies have shown no benefit at all compared to placebo.
All right. Well, it's 7:30. I would like to thank both of the presenters for their excellent presentations and the lively discussion. And I would also like to thank the audience, our colleagues, for joining in tonight. It was great having you. We had close to 400 participants at max, which is great. And I would like to very much thank the EAU for setting this up. I think it's a very nice format. It's very informative. I would like to invite you for our the last of those 3 modules, which is going to be about invasive treatment for male LUTS. Having said this, I wish you all a very good night, and I thank you all for your participation. Thank you.